With Chapter 3, Conception and Development of the Embryo and Fetus, you want to pay close attention to the hormones of pregnancy, to human chorionic gonadotropin, to human placental lactogen, the roles of progesterone and estrogen, oxytocin we'll talk a little bit about, and that goes into Module 2. You will want to learn about amniocentesis and chorionic villi sampling, teratogens in the first trimester, and then we'll talk about the placenta, its purpose, and those placental hormones again, and how sometimes issues with the placenta can be precursors to complications such as gestational diabetes, preeclampsia, and then also placental complications like abruption, previa, RH and ABO incompatibility. So fertilization happens at week 1. It's about 2 weeks after the last menstrual period, so right around ovulation. If a sperm meets an egg successfully, we call that fertilization, and then it forms a zygote, which is a diploid cell, 23 chromosomes from the male, 23 from the female. Usually this takes place in the outer third of the fallopian tube near the ovary, and as soon as it does take place, a chemical change in the membrane of the egg prevents further sperm from penetrating. So another thing that has to happen for a successful pregnancy is implantation, which is week 2 or about 4 weeks after the last menstrual period. So again, we said fertilization happens about here, like in the fallopian tubes. After about 24 hours, the fertilized ovum or the zygote travels to the uterus. While it's traveling, it's multiplying and differentiating. After about 3 or 4 days, it now has 16 cells. It's called a marula, because that's the Greek word for mulberry, so it's similar to a raspberry. It enters the uterus, and then it's called a blastocyst. And this blastocyst contains an inner cell mass and an outer cell mass. The inner cell mass being the embryoblast, which is eventually what gives rise to the embryo or fetus. Embryo and then fetus. And then the outer cell mass is called trophoblast. Those trophoblast cells are what become the chorion and the placenta. Implantation begins as those trophoblast cells invade the endometrium, and this occurs about 10 days after fertilization. So this is a good visual of that implantation. So again, it's just interesting to remember one sperm cell, one egg cell, and it becomes everything. It becomes placenta, it becomes embryo, it becomes umbilical cord, it becomes amniotic sac. All of the things that end up with a human baby at the end start from that one single sperm cell and that one single egg cell. So we have something called a yolk sac, which forms about day 8 to 9. It supplies nutrients before the placenta does. So it also produces red blood cells from about week 3. And in humans, it shrinks at about 8 weeks as the fetal liver takes over the red blood cell production. Eventually, it atrophies completely and becomes part of the umbilical cord in humans. Those yolk sac vessels contract, and they form 2 umbilical arteries and 1 umbilical vein, which we refer to as AVA in this class, just to help you guys remember easily. And the maternal blood flows through the uterine arteries into an intervillous space, into the uterine veins, and throughout the maternal circulation. Fetal blood flows through umbilical arteries into villus capillaries, in the umbilical vein, and into fetal circulation. So it's important to understand the fetus and the mother are connected through the umbilical cord and the placenta, but their blood flows don't actually really combine or mix. They do have 2 separate cardiovascular systems and 2 separate circulatory systems. The fetus just kind of takes what it needs from a pool of blood that the maternal side of the placenta offers. We'll talk about fetal circulation and cardiac defects when fetal circulation doesn't change as it should as soon as the baby's born and takes its first breath, but that's more on Module 2. So fetal membranes and amniotic fluid. The fetal membranes, this video is very helpful in visualizing that. There's outer membranes, which are called the chorion. Again, they come from those trophoblast cells. They contain finger-like projections that can be used for genetic testing. This can be done as early as 8 to 13 weeks. It can be used to test the fetal genetic makeup. It is a high-risk test, so it's not offered to everyone, unless there's issues with genetics, or sometimes it'll be offered to older moms. It is associated with spontaneous abortion or miscarriage and fetal limb reduction. So again, it's not without risks, but it is an early test and it can be diagnostic for genetic issues. Eventually, these chorionic villi grow and branch into the wall of the uterus, which forms the fetal portion of the placenta. So if you can imagine the inside of the uterus has 3 layers. The 2 innermost layers are what become the placenta in a human pregnancy that's successful, and that is the lifeline to the fetus through the placenta and the umbilical cord. That's how the fetus gets nutrients, it's how it gets oxygen, and that's how it gets rid of waste in utero. The inner fetal membranes are called the amnion. It's a thin protective structure that contains the amniotic fluid. Eventually, the chorion encloses the amnion, the embryo, and the yolk sac, and the chorion and the amnion fuse together. So when you hear those words, chorion and amnion, they're basically just 2 sides of the amniotic sac, which is filled with fluid. This is important because women can get an infection. If you hear something about chorio on a labor and delivery floor, it's a maternal infection of those amniotic membranes, and it can cause an inflammatory response. So amniotic fluid, which is inside that sac, is vital for growth and development of the fetus. It cushions and protects the fetus. It acts as a shock absorber. It helps maintain temperature. It aids in fetal musculoskeletal development by allowing for movement. So if you can imagine it, we have the uterus, and then we have the amniotic sac, and then the fluid inside the sac is what the fetus can use to move around, to maintain its temperature, and is a shock absorber while the woman is pregnant. And again, this fluid is dynamic. It changes as it moves across the placental membrane. So there's something called an amniocentesis, which is needle aspiration of amniotic fluid to determine chromosome analysis. This is performed around 15 to 20 weeks at the beginning of the 2nd trimester. It's important for nurses to know that there are risks: spontaneous abortion, vaginal bleeding, RH isoimmunization, and leaking of amniotic fluid. Again, it's for high-risk women, for older women, for women that know they have issues with, or that are thinking they might have chromosomal issues. It's not a standardized test, but it is something that's offered to women that are in the high-risk category. It's important for nursing students and nurses to know that it can take up to 2 weeks to get your result. So if you're getting a diagnostic test done around 15 to 20 weeks of pregnancy, and you might not get your results for 2 weeks, it's important for that consultation to happen so patients can really understand what their options are at that point. This is a great depiction of the placenta, the amniotic sac, the umbilical cord, and how everything is sort of laid together. It helps to really visualize it in a 3D model. I would check it out. So the placenta function, again, we talked about those trophoblast cells. They invade the endometrium for that first month or so. So right here, this is really only, day 25 to 35. This is about 5 to 6 weeks pregnant. The cells reach the maternal spiral arteries. Most of the time, those uterine arteries remodel and they dilate 5 to 10 times their size, because all of that blood flow is going through mom, through umbilical cord, through placenta to baby. About 40 to 50% higher blood volume than a non-pregnant woman. So they think what happens with preeclampsia is there's poor remodeling of those spiral arteries, and they're constricted and not as wide as they should be from implantation. So how the placenta works is maternal blood forms intervillous spaces around the villi, and there's blood reservoirs that can supply the fetus with oxygen and nutrients. So the fetus is basically sort of grabbing what it needs from a pool of blood. So again, the blood supplies are not mixing, but the fetus is getting what it needs from that placental blood supply. This is usually established by about 8 to 10 weeks, and it is acting as a metabolic organ. So it's acting for gas exchange, for oxygen, for nutrients, for waste, and it also is important because it has several hormones that it secretes to maintain a pregnancy. So depending on what is being transported, it's transported differently. So simple diffusion, narcotics can be transported, antibiotics, anesthetics. Glucose and oxygen are through facilitated diffusion. Amino acids, water-soluble vitamins, calcium, iron, that uses active transport. And then certain viruses, certain antibodies, the bacteria that causes syphilis can independently transport itself over the placental membrane, so that's why it's important to have testing early on in pregnancy. It's important to be able to know if you need to treat an infant, because that bacterium that causes syphilis can transport across the placenta. Placental hormones that you'll need to know are human chorionic gonadotropin, human placental lactogen, progesterone, and estrogen. The full list of hormones that will help you to understand reproduction and conception and contraception are in this list that you can click out and link and read. HCG is what is responsible, they think, for nausea and vomiting, and what you're measuring in a home pregnancy test is HCG. We don't take it as a positive sign, a positive pregnancy test. We use it as a probable sign because HCG is very similar to luteinizing hormone, which men also have. So if you get a positive pregnancy test, they will still use that as a probable sign of pregnancy, which we'll talk about in the next slide deck. The levels of HCG peak at about 10 to 12 weeks gestation. Earlier than that, they're doubling each day because of that cell differentiation, because all those cells are just growing and dividing and growing and dividing. So about 10 to 12 weeks around the first trimester, it sort of levels out. If there's any time during that time, if there's steady or dropping levels, then you might want to look at an ectopic pregnancy or spontaneous abortion. If you see abnormally high levels, it could be a molar pregnancy, it could be twins or triplets, multiple pregnancy, or it can sometimes mean chromosomal abnormalities. HPL, or human placental lactogen, increases the glucose for the fetus and promotes growth, along with human growth hormone and cortisol. So it's an insulin antagonist in women. It decreases maternal metabolism of glucose to favor fetal growth. So most of the time what happens, the pancreas compensates by increasing the insulin production in the women. But in women who can't meet that increased need for insulin production, they have an altered carbohydrate metabolism and end up with hypoglycemia or gestational diabetes. So because insulin doesn't cross the placenta, the fetus has to make more insulin because of that glucose in utero. And then when they're born, because they don't have that high glucose anymore and they're continuing to make insulin, they can be at risk for hypoglycemia because they don't have that source of glucose. So high maternal glucose also in utero will give you those big babies, so a macrosomic baby. So it's just important to understand how the hormones and how the placenta works in a normally growing fetus, in a normally, in a normal pregnancy. Basically, pregnancy is like a stress test for your body. Women that have gestational diabetes are 50% higher. They have a 50% higher chance of developing type 2 diabetes later in life. So they also have found that women with preeclampsia have a higher risk of having cardiovascular disease later in life. So basically, your body is designed to have a pregnancy. It's designed to, do all these things to provide growth for the infant, to have all this extra blood volume. And sometimes women find out with pregnancy that the stress of the pregnancy is sort of a precursor to these issues later on in life. Progesterone, it prevents maternal immune rejection, it relaxes smooth muscle, reduces uterine activity, raises body temperature. It's called the hormone of pregnancy, because it promotes successful implantation. So again, we talked about in the first slide deck, if estrogen's sort of boosting blood flow to the uterus, getting that, follicle to get ready to be released, progesterone is sort of getting that uterine lining and getting that uterus to be a safe place for the zygote to land. It inhibits contractions of the myometrium, and progesterone also decreases airway resistance, allowing mom to have 15 to 20% more oxygen consumption. Because again, all that extra oxygen, all that extra blood flow, that has to go through the placenta to the fetus so the fetus can grow in utero. Estrogen promotes maturation of the ovarian follicles, which we've talked about in the first slide deck. It promotes growth of the blood vessels in the endometrium. It stimulates breast growth, and then it has its job of initiating development of secondary sex characteristics, reproductive organs, breasts, hips, fat deposition. Specifically in pregnancy, it boosts blood flow to the uterus, and it softens the cervix when it's time to start to ripen and go into labor. The full list of hormones to know are here. Again, I would concentrate on what HCG does. I would concentrate on follicle stimulating hormone and luteinizing hormone, like we talked about, where it is secreted, what their jobs are, HPL and how it works with gestational diabetes, progesterone, and estrogen. And then in Module 2, we'll talk a lot about oxytocin and how that helps with the initiation of labor and how it helps with breastfeeding. After about 5 to 6 weeks after the last menstrual period, you have the development of the notochord, precursor to brain and spinal cord, the differentiation of the 3 germ cell layers. You don't need to know this. What you need to know is that all of this early development, the nervous system is particularly vulnerable to environmental insults. So if 5 to 6 weeks after your last menstrual period, all of this has happened, skin, teeth, the inner layer, the middle layer, bone marrow, skeletal tissues, blood, brain and spinal cord. It's important for women to know about educating. It's important for nurses to know about educating all childbearing women about the importance of folic acid, which is shown to reduce the incidence of neural tube defects. So we recommend 400 to 800 micrograms of folic acid daily to all women of childbearing age. I believe ATI says 600 micrograms once you're pregnant, but you need to understand that if you're not even getting, you're not even missing a period until right about now, all of this has already happened. So during those early weeks, that first trimester, the embryo is particularly vulnerable. So you want to educate women about the importance of folic acid. By about 10 weeks after the last menstrual period, there's a clear distinction between the upper and lower limbs. External genitalia has developed, there's a human appearance, and the main organ systems have begun to develop. With the exception of the cardiovascular system, they have minimal function. So weeks 2 to 8, again, that embryo undergoes rapid growth and differentiation. It's a time period called organogenesis. It's extremely vulnerable to teratogens such as medications, alcohol, tobacco, radiation, maternal torch infections. So we need you to read about torch infections on page 73 to 77, and we'll talk about them in the next slide deck. But they're especially important in this first trimester because of their teratogenic effect and the detrimental effect that they can have on a growing embryo and fetus. So fetus, they call it a fetus once it becomes about 9 weeks, 9 to 40 weeks. You can read about the fetal period. Pregnancy, again, is divided into trimesters. There's 3 trimesters, each about 13 weeks long or so. At about 24 weeks, the fetus's lungs begin to produce surfactant, which is a substance which decreases surface tension in alveoli and is necessary for survival. We'll talk about that in Module 2 with prematurity. But again, because the placenta is sort of acting as the liver, it's acting as the lungs, it's getting rid of waste products, it's doing gas exchange for the fetus, they don't need their lungs the same way that we do outside. Basically those lungs are filled with fluid because of the amniotic fluid in utero, because they don't need them the same way. So we'll talk about that, and we'll talk about, when we see those preemie babies that are born at 23 and 24 and 25 weeks, how that affects them early on in life and how it can affect them further on. So here are just links to see what all is happening in the first, second, and third trimester, what's growing, what's happening in utero to give you a better idea. Genetic laboratory testing that you might see and would need to know about are cell-free DNA is something that can screen for trisomy 13, 18, and 21. Any positive should be followed up with a diagnostic test. This can be done as early as 10 weeks. It can also provide information about the fetus's gender, so a lot of people will do that. It's not always covered by insurance. Another screening test is the alpha-fetoprotein. It's a test on mom's blood. It's done about 15 to 20 weeks. Low levels could indicate genetic conditions such as Down syndrome. High levels could indicate neural tube defects. High levels could also indicate twins. You're not supposed to, or in general, you don't have high levels of this alpha-fetoprotein circulating in mother's blood, so that's why it can give you an idea of if there's an issue with the neural tube defect in utero, and that is leaking into the maternal circulation. Again, both of these are screening tests, and the CVI and the amniocentesis, which we talked about, are diagnostic. So chorionic villi sampling is an ultrasound-guided needle aspiration of tissue from that fetal side of the placenta. It can be done as early as 8 to 13 weeks. Again, it's for high-risk women, and spontaneous abortion and limb reduction can occur, so a lot of risk versus benefit education needs to be done. Amniocentesis is a needle aspiration of amniotic fluid for chromosome analysis. Again, it's diagnostic, offered to high-risk women, usually not done until about 15 to 20 weeks. There isn't enough fluid before that, and there are risks involved, including spontaneous abortion, vaginal bleeding, leaking of fluid, again because that placental membrane is sort of separating the mom and fetus blood. There's risk for isoimmunization if you're doing anything that can compromise that, which a needle aspiration of fluid could do. So there's a risk for that, and results can take up to 2 weeks, so it's important for nurses to know, if you're getting a diagnostic test done at 18 to 19 weeks pregnant, it could take you 2 weeks to get the results. You really want to educate women on, what their options are going to be at that point. A lot of nursing education is just going to be about timing, the risks involved, the limitations, and then therapeutic communication depending on what sort of results that they get back.